All right. Hello, everyone, and welcome to week 7 of the Rugby Research and Injury Prevention Group's 2023 Summer Lecture Series. My name is Sagar Singh, and I'll be the conference chair for today. I'm an intern for RIPG and currently a student of the St. Louis Early College program. I'd first like to say thank you to our viewers throughout the world listening in through conference call. Today, our guest speaker is Dr. Richard Ma. Dr. Richard Ma serves as the team physician for Mizzou Athletics. He was also the former assistant team physician for the New York Knicks alongside Dr. Allen, affiliated with the NBA. And moreover, he has served in a variety of orthopedics and sports medicine leadership roles, including serving as vice president of the Missouri Orthopedic Institute. And for his strong commitment to the field of medicine and research, he has won many clinical accolades, including being named Inside Columbia Magazine's top doctors. Dr. Ma, if you'd like to take it away on your presentation.
Okay. Well, I appreciate the kind introduction here. I may need to be able to share the screen. So Vic, I may need to get the permission to share it because it says it's been disabled.
Yes, Dr. Lopez, could you transfer over the host permissions to Dr. Ma?
Okay. Are you guys able to see just the presentation itself?
Yes.
Okay. Well, it's a pleasure to kind of talk with you guys this afternoon. Like, I think, for me, Dr. Lopez had wanted me to try to give a knee specific talk if I could, and I decided since this forum has both students of varying kind of training degrees to kind of talk about meniscus injuries because this is an area where it's kind of changed a lot. I think for me, ever even since my fellowship, and I finished my fellowship at HSS back in 2013. And how I approach meniscus injuries now is different than how I learned it when I was a fellow. I'll talk a little bit about what that is in terms of the importance of the meniscus. And the other reason I kind of brought this forward is because we see meniscus injuries fairly frequently. It's one of the more common things that people can have surgery for if you go see an orthopedist, which we'll talk about a little bit. And so let me kind of move to this next slide here. And so I don't really have any immediate disclosures in terms of things that are in conflict with the content of this talk that I'm about to give. And what I put on here in this picture a little bit, because I think for some of you guys are new. I've never met before, but it's just a little something about me in terms of my background and my training. And so I did my undergraduate at the University of Virginia, where I spent my undergraduate, my medical school, and also my orthopedic training at the University of Virginia. And then after I was done with that, I did my sports medicine fellowship at the Hospital for Professor of Surgery in New York, and that's how I met Dr. Lopez. Once I was done with my orthopedic training, I transplanted myself to mid-Missouri, which is in the middle part of the country. I don't have any connections here, but since being here, I now have roots here. I've got 2 young kids that were born here in mid-Missouri, so they're actually Missourians. I'm more of a transplant, but you can see the Orthopedic Institute, and these are some of the people that I work with. And for some of you guys who may not know what I do, in addition to being a clinician, I'm also teach. And because I have a sports medicine background, I cover a variety of teams here for University of Missouri. And what you see there is actually one of our men's basketball games, and we have a pretty exciting year this past year. We had a big leap in terms of success of the program, so it's pretty cool to be a part of that. And then I'm also a student like a lot of you guys. So that I teach and I take care of athletes. I'm also a student, so I'm in the middle of completing my PhD degree. So in some way, life is kind of like a journey and continue to learn. And it's very relevant for this talk because as it pertains to meniscus injuries, I'm still learning, and my approach to it is also continuing to evolve because of new knowledge. And so this is actually me back in 2013. This literally was in my office before I took on my first surgery. This is my very first surgery out of fellowship. And it was actually an ACL tear. But what you see here on the right is the arthroscopy videos from that ACL tear. And this guy had a huge bucket handle tear of his meniscus. And that's what you see. It's basically locked out in the front of his inner side of his knee joint. This was a chronic tear. This had been there for probably at least 3 months, but it was reducible. And I could tell you what I did at that time with that surgery. You know, I went ahead and removed that meniscus because I thought chronicity-wise, meaning how long it's been there, would have precluded that guy from healing this injury. It's probably not how I would approach this now in 2023. I think if it's reducible, I think you should make every effort to try to give somebody a chance to save the meniscus, because once people start to lose that, there are some biological cascades and things that happen that is irreversible. And so that kind of forms the foundation and one of the themes I want to kind of talk to you guys about in terms of how we approach meniscus injuries now in athletes. And so I'm going to give you another patient illustration, okay? So this is a 52-year-old female, you know, pretty active, works in a factory. She was having kind of medial-based knee pain, and you see her x-rays, and this is her left knee MRI. And then you can see the arrow pointing to the small radial tear that she has on that knee MRI. And this case illustrates the importance of the meniscus. Okay, and her x-rays at that time, in terms of the joint space on that left knee, you know, looks pretty good compared to the other knee. Okay, but the tear is small. And so she didn't want to have surgery. She had undergone a surgery before, didn't do really well in the sense that she had a hard time with that recovery process. We tried a little bit of non-surgical rehabilitation. So in the span of 2 to 3 months, that little tear went on to a complete tear. What you see now in that meniscus is that that little gap that you had initially seen is now a very wide gap. And the meniscus had completely extruded now. So now this is turned into a situation where the meniscus has completely failed, right? And you can see that her alignment, which is that center picture, just how bowed that leg is, right? So that's her underlying risk factor. And radiographic wise, look how narrow that joint space is. This happened rapidly within 2 to 3 months. So once that meniscus goes, sometimes you get these rapid progression of arthritic changes that are irreversible. And so she went on to have prosthetic reconstruction of her knee because of this, because at this point, with that kind of wear that developed within a short span of time, the damage that she accumulated was irreversible on some level. So this highlights how the meniscus function may be very vital, and that once you lose it, how fast the knee goes in terms of starts to kind of give out on the individual. This is a different case, okay? And this just kind of highlights maybe how important it is to think about the meniscus in terms of the overall health of the knee joint, and also how it may impact a person after surgery. And this is a different individual, different age range, under 20, who has already had an ACL reconstruction. But unfortunately, he also had meniscus injuries that the prior surgeon had a difficult time fixing. And he had failed some of those repairs. And so you see these x-rays, but he was playing basketball and basically injured his knee more. Okay, so what I'm basically showing on this MRI on the right is a few things. Okay, if you look at that inner meniscus, the medial side is torn. Half of it is pushed out into the middle part of the knee joint, which is that center arrow. It's kind of stuck, kind of like that first video that you saw with the knee, with that meniscus kind of flipped and stuck in the middle of the joint. But if you look on the outer side of that guy's knee joint, look how much meniscus he's already missing. He doesn't have a triangle like you see on this inner side at all. It's very diminutive because from his prior surgery, that surgeon had cut out a lot of the meniscus already. And you can already see on that side of the joint how flat that part of the joint looks. These are what we call Fairbank changes, which is arthritis changes. And this is the 19-year-old. Okay, so many of you guys probably are maybe even older than this guy, but he already has a knee joint that we would consider to be orthopedic already, which is a big deal for a 19-year-old. Okay, and so this is what his picture looked like, where he had that flip meniscus stuck out in the middle of the joint. And then the outer part of that knee where you don't see much of a meniscus at all, that's all he had left on the outer part of that knee joint in terms of the arthroscopic images. And on the far right picture, you can see some smooth areas, but also some rough areas, which is indicative of some arthritis changes already starting to develop on the outer part of that knee. And so my objective today is to kind of talk about the anatomy and the function of the meniscus, and then considering the function of the meniscus in terms of some of the decision makings, like, in terms of what we do in terms of how to treat these injuries. And so hopefully, and this is what's kind of changed in my career, cleaning up a meniscus tear is it's a fun surgery. For those of you guys who've never been in the operating room, that's a cool surgery to see. It's an arthroscopic surgery. It's almost like a video game where you go in there, you look at it, and you do some shaving and cleaning. But I'm doing less and less of that fun surgery in 2023 than I did in 2013, because what I'm trying to say is that we're kind of moving the field goal post now, where we're trying to be more aggressive, trying to save the meniscus in different scenarios rather than try to trim the meniscus, because we're recognizing the importance of the meniscus in terms of the preservation of the joint, especially in healthy, active individuals. And so if you look at the incidence of meniscus tears, this is mostly based off of the NCAA data list on data. You can see that's fairly common among athletes. It's just behind ACL tears and MCL tears in terms of the relative incidence of this, at least in that capture system in terms of the NCAA injury surveillance data. And you can see that a lot of these individuals, a lot of these end up having surgeries. And what you see on the video on the right is basically, a meniscus tear that has now been cleaned. You can see, it's kind of a fun surgery to do. I mean, like you find the tear, you probe it. If it's unstable, like this tear that you see here on that picture, you could get a little scissor in there and you could clean it. So in that scenario, the idea is that, that meniscus tear is probably non-functional and maybe not salvageable. And then it's kind of like a hangnail and you kind of clean it. And so it's a very common surgery that we do in the US. It's maybe the most common surgery that actually happens among orthopedic surgeons in the United States. But the meniscus has a function. So there's no free lunch, okay? You don't get to just take out things and not think that that has some consequences. And so I listed maybe 4 of the main things that the meniscus helps with. It is chondroprotective. So in some ways, because of its shape, it could distribute the force across the cartilage so that there's less sort of edge loading of the knee. And so in that way, it helps protect cartilage. And it also helps with joint stability. It's a secondary stabilizer in people that don't have a healthy ACL. It's kind of like a doorstop that prevents the knee from being slid out anteriorly. It's also important in joint lubrication and also has some proprioceptive functions. And so what you see on the boxes on the bottom is how some of these things may be interlinked. One of the things I want you guys to kind of think about, because like a lot of times when you think about the knee, you think about the ACL, think about the cartilage, you think about meniscus, you think about the bone. You tend to kind of think that all these are separate, discrete structures. But the reality of the situation is that the joint is an organ. So it's actually one functional unit. And then when you have a meniscus that's given out, there is a biologic cascade that may happen that then impacts the health of the other parts of the knee. And so instead of thinking of the meniscus as an individual part, it's probably a vital part of the entire organ, which is in the knee joint. And when you have one of those missing or not functioning property, you can lead to things. So that's what those boxes on the bottom kind of shows, is that when you have some meniscal deficiency, not only can you lead to some arthritic changes, but because the joint is now less stable because it's lost one of the stabilizers, can lead to a failed ACL graft. And once that graft fails, that inner meniscus or the medial meniscus, which is the secondary stabilizers, is going to work overtime to try to help keep the knee in the right spot. But eventually that even fails, and that can lead to the tear, which is what that second patient that I showed you, presented with. Okay. So for those of you guys that may not have seen what meniscus actually looks like on a cadaveric specimen, it's a pretty incredible piece of tissue considering what it looks like. It's kind of two moon-shaped discs. You have an inner set, which is the medial side, and then you have the lateral side. And then a lot of the anatomy of the meniscus has improved since I was a fellow HSS. We now understand not only the geometries of these meniscus, but also the important attachment points, which allows us to kind of fix some of these injuries that I didn't see a lot of when I was a fellow, like root injuries. And so we have a better understanding of the anatomy, which allows us to have a better understanding how to kind of fix some of these things. And there's just some certain concepts that I wasn't exposed to even just 10 years ago. The concept of the meniscotibial ligament, which is that orange structure on that pictograph on the top left. That concept wasn't very clear to me when I was a fellow. And so we're recognizing that that might be important, especially in certain areas like a root tear. So if you looked at that picture on the right here, this is that first patient that we saw. It started with a small radial tear in the back of the knee. And you can see the meniscotibial ligament, which is that yellow arrow. But once you lose that root attachment, she had a functional root tear, even though it was a small radial tear, not exactly at the root, but it behaved like a root tear. You see that belt basically give away. It's no longer there on the yellow arrow. And so that leads to the extrusion. And then the importance of considering that in the repairs that you do is an evolving concept. And that leads to some of the surgeries that people do in addition to root repairs to kind of help individuals that may have extrusion of the meniscus. And so I think the meniscus tissue is super interesting because when you look at it microscopically, it looks like the end of a clam. That's the way I describe it to a patient, right? But if you can look at it under scanning electromagnetic microscopy, when you get to see these fibers, it's pretty cool how this is organized. It's very intricate. And so within the tissue itself, you have these cables or these collagen bundles that basically run in parallel, kind of like a C, right? And so these cables, because they're running circumferential, and these are the main fibers, when you step on these, they expand. And then when you take off the load, it contracts, right? And so it's pretty cool to see how this microscopic structure leads to the function of the meniscus. But it also has these intricate weavings. So it's got some random fibers that are also in perpendicular to the longitudinal fibers. And because of the way it's put together, you can see how, when you compress on it, which is this central picture, it helps distribute the load. You can see how it expands and then it also contracts. And so it's pretty neat when you think about how this tissue is elegantly organized to provide the function that it has. And so the other thing about meniscus in terms of just the function is its vascularity, right? And I'm on Zoom, so you guys can't see this very well, but I always show this to my patients. I've got this cut on my thumb that is a pretty gnarly cut. I remember the day I did it. But like a skin cut, every time you cut yourself, unless it's a serious health issue, you're always going to heal it, right? Because it's always going to bleed. It's going to lead to a clot. And then that clotting process leads to a scar. And then that scarring process eventually gets remodeled and you get somewhat of a normal looking skin. It's not maybe as pretty as the normal skin, but something heals. The meniscus is interesting because what you see on this picture on the left here, the vascularity doesn't go all the way through the meniscus, okay? Most of it is concentrated along the outer rim of the meniscus. And so as you get more toward the center, it gets less and less vascular. And what that may mean is that the ability for somebody to heal an injury that's located along the inner side may be diminished because it may not have the vascularity and the ability to transmit the necessary things to start that healing process. But as we kind of, and I'm going to talk about this a little bit with some of the atypical tears, we're starting to realize that this is not always true, that we can maybe be more successful fixing some of these tears that are along this inner side, like within the red-white zone, sometimes even the white-white zone. And that maybe there's a chance that you can still heal those, even though the traditional thinking is that you can only fix the ones along the outer rim here. And so this is a study that kind of illustrates what happens when you start to lose the meniscus. And your chance in terms of cartilage injury risk and osteoarthritis risk is proportional to how much meniscus tissue that you remove. So I know a lot of you guys are not biomechanic specialists or particularly studying these models that shows pressure mapping. But in this two rainbow color picture, basically red is high stress, okay? And so you can see in the intact meniscus state, and blue is low stress, okay? When you put pressure across the joint with the intact meniscus, you can see that most of the colors are in the light blue to green, and then there's maybe some orange and yellow areas, but you don't see a lot of red areas, okay? But when you have an injury where you started to kind of lose the meniscus function, like a root tear, or you trim out a good portion of the meniscus, you can see what happens is that you get that edge loading that I was talking about, where there's an increase in contact pressure under the same loading conditions. And so that diagram here in the center kind of illustrates that, where if you had a wider contact surface area because the meniscus has increased the surface area by being sandwiched between the joint, you don't have as much edge-to-edge loading. Everything's distributed through a wider area. Whereas once you lose that, you get a high concentration right in the convexity of the condyle. What happens is pretty neat, like when you repair things, so you have a tear and now you repair it, that contact pressure goes back down to closer to normal. It's not completely normal, but it is closer, and those red areas kind of go away and they're diminished. But it's still not quite completely normal. So it's, if you look at the repaired versus intact state, it's not exactly normal, but it is definitely better than partial, where you've already lost some function here. And over time, and this is what I showed you with that first case, if you lose your meniscus function, right, you can look at loss of joint space. In that second case, you get squaring of the condyles, and these are early orthopedic changes that happens in people that have had a loss of the meniscus function. So that's how you can see the health of the meniscus on a radiograph, okay? And so whenever I'm in surgery, I mean, these are the decisions, really the three decisions that you can do if you see a tear, okay? You can either leave it alone, you can clean it, or you could try to repair it, okay? And you can see, just like a piece of paper, if I gave you guys a piece of paper and told you to rip it, you guys probably may rip it in different directions. There's a variety of ways you can tear the meniscus, okay? And so these are the different patterns that you see on the right here. And I do think some of them are more amenable to fixing it. And so for me, like things that maybe be able to leave alone are like the longitudinal, meaning straight tears that may be not very long. So they're kind of like tiny rips, but like they're stable. And if they're located particularly along the periphery of the rim, especially during ACL surgery, I think those can be left alone without needing any stitching and things like that. The ones that are more likely to get debrided, and so if you kind of start thinking about the anatomy and then how does that play into surgical decision making, the ones that are along the inner side of the joint, on the white part, far from where the vascularity is, those are more likely the ones that probably then get debrided. Because one, it involves a very small part of the meniscus, and two, the capacity to heal those may be greatly diminished versus tears that may traverse more to the periphery. The other reason I put on here that sometimes you may end up debriding the meniscus, and this only happened maybe one time in my career, is if the meniscus tissue just won't hold any stitches. So sometimes, like if you're operating on the older individual and the tissue is very compromised, the stitches will pull out. I've had that happen one time in my career when I was trying to fix a meniscus tear in the individual that were in their 60s. Right now, age is not a requirement for me to choose whether or not to do a meniscus repair or not. I dictate that based on really quality and tear pattern more than I do age, because I think anybody can really benefit from having a functional meniscus if it's amenable to a repair. In terms of meniscus repairs, in the ideal situation, the longitudinal tears are the ones that are nice to fix. They're located right along the rim, high healing capacity, and they're more likely to be stable after you stitch it. And they may even allow you to utterly weight bear. Unfortunately, my practice, out in Missouri, I don't have the ideal scenario very often. So I'm often presented with tear patterns like the radial tear, which sometimes, if it goes all the way out, go through all three zones of the meniscus, and that completely destabilizes the meniscus, and the meniscus loses its function, like that case number one. I've obviously seen my share of bucket handle tears, which I've already shown you 2 cases of. And so these seems to kind of attract me for whatever reason. They come to me. I wish they would go find somebody else, but because these are challenging. They're challenging from a healing perspective. And then in some of these, like a bucket handle tear, they take some time to put back together. And so there's some things that's helped me in my practice in terms of my ability to fix these. Okay. So I know a lot of you guys have not seen surgery, but this just gives you an idea like what this looks like. So it's not like you're looking at something and you just can stitch it like with your hands. Okay. In arthroscopy, which is a lot of times how we do this, we're working in tight spaces like that. See how tight that space is, right? You can't even see the back of that meniscus. Okay. So access and being able to see what you need to fix is an important part of surgery. My computer. Kind of frozen here. Big. I may have to restart this.
Sorry, I had my mute on. I'm sorry about that.
No, you're good. I think the computer froze here. Let me give me 1 second here.
All right.
Sorry about that technical difficulty. It was going too well. Okay.
Usually.
But that's okay. We can do it again. All right. 1 second here.
Mm.
Okay, are you guys seeing the videos again? Okay. But there are now ways, I think, for me, that you can access that, and this is the way I do it. You can kind of loosen up the medial collateral ligament a little bit with just some controlled punctures. And you can then see that after that, now you can see more. You can see how much wider that space is. So then that lets us then be able to do a variety of things like create enough space. And here's another bucket handle tear in a different patient to kind of put it back. Okay, so that's how that works together and helps you achieve a repair. So that's an important thing that's kind of developed my career that has allowed me to see things better and allowed me to access things and repair things and put things back together. And so the other thing that has helped me is just identifying ways to see. So this, looking from the front, right, you can't see this tear. So you have to understand your MRI and know where to look, right? But you just get the sense like there may be a crevice back there but from the front, you just can't see it really well. But these ramp lesions and recognizing what ramp lesions may look like and also suspicion helps you then go to the back of your knee joint, which is what you see in the center box. We go right behind the bone, the condyle. And then you can see using your 70-degree camera, now you can see this tear very clearly. And so understanding the anatomy, how to access the area you need to look so you can evaluate tears further, helps you recognize injuries that otherwise with standard knee scopes, sometimes you may miss, okay? So that's another thing that has helped me is just understanding how to read my MRIs and when to be suspicious for something so that I don't miss some of these injuries that may be hard to see. Right. And so the other thing is you have to have the right tools, okay? What I mean right tools is that you got to bring a lot of tools in terms of in your toolbox to fix these. I wish I could tell you that you can fix it all one way. But depending on the tear, you got to have abilities to put stitches from the inside out, put stitches all the way from the inside, from outside in, and in some instances use repairs like open repairs. And so, you know, that one that I showed you in the beginning is how it got fixed. We use shoulder instruments to kind of put these little stitches around to allow you to kind of close that hole that you had in the beginning. In this instance, what you see on the top right here is a person that had a really bad injury, basically blew out the inner side of her knee joint. So she had a complete MCL tear. But through the MCL, you can basically look from the inner side of her knee all the way into the knee joint itself. So that's the extent of her soft tissue injury. You can see the meniscus in the center with the stitch. And so we did an open repair in this instance. I don't get to go back and look at people's meniscus repairs very often because I usually don't have to do another surgery. But in this instance, she had another ligament that I was planning at the stage, but I got to have a chance to go back and look at this repair. And you can repair some things that and make it look pretty normal. And so you have to bring all these toolboxes in just so you can fix these things because there's no one way to fix it. You have to use all the combination of the tools to kind of fix all of these things, okay? And so what are the outcomes of this? So longitudinal tears are the ones that do the best, okay? That's the traditional, that's why I would say like those ones are the ones that you ideally want to get. But some of these atypical tears probably do better than what we think it does. And so that's what the literature is starting to show is that even for some of these things that we used to clean, like horizontal tears, if you fix them, or the radial tears, which is really bad, the one that goes all the way through all three zones of the meniscus, you can see that they have a reasonable success rate. They're all above 50%, so more likely than not to heal. And so because of that, you know, I'll go back to that moving that the field goal post. We're going from a situation now where we think not just debridement first, but the question I ask myself all the time is, can it be repaired? And so I'm thinking repair first rather than debridement first, which is a big change for me compared to when I first came out once I was done in fellowship and started my practice. And so I'm going to go back to that, one of the cases that we had in the beginning, okay? So this is that kid that had the ACL re-tear, graft re-tear, the bucket handle medial meniscus tear, and then the ailing lateral compartment where he's missing a part of his meniscus. And so this is his bucket handle meniscus repair. So we did that in the first stage surgery, and you can see the stitches, and now it's healed. Okay, so it's pretty cool to see it on his second surgery that he's healed this bucket handle tear. For his lateral meniscus, we did a meniscus transplant. There's no way to give him more tissue other than to take a fresh meniscus that somebody generously donated because they were a body donor, they're an organ donor, and give him a meniscus where he otherwise didn't have it. And then we did his ACL surgery, and that's his new graft that we put in. Okay, so in that one case, basically we have identified the things that in the organ that's not working, and try to address each one of those individual things to hopefully restore the balance and homeostasis of that knee joint organ. Okay, so the conclusion, I think, for me, hopefully you guys gain from this that you understand that a meniscus has several important functions that's critical to the long-term health of the knee joint. I think the improvement in terms of our understanding of the anatomy, our instrumentation and better recognition has allowed us to kind of be able to not only identify these, but fix some of these things that previously, we hadn't thought about fixing. And so the hope is obviously that long-term wise, that not only do we achieve healing, but we're also able to salvage the knee joint rather than trimming the meniscus, which I've already shown you can have downsides in terms of long-term health of the joint. And so for me, I've always erred on the side of meniscus preservation if I can. So that's the way my thinking is now. I ask myself, can I repair this more than I do in terms of debridement? And so I'm fairly proactive about fixing meniscus. So that's it. All right, any questions?
Jaco, I want to first introduce myself. My name is Sarah Francis. I just graduated from Tulane. I did neuroscience and public health, and I'll be starting my MPH in the fall. So I know you mentioned that with improvement in instrumentation, better recognition of the anatomy that has helped surgeons. I was wondering still now, despite that, what parts of the meniscus are least understood and what research is underway to better fill those gaps?
Yeah, I think to me, there's a couple of areas. Like that slide that I showed about meniscus root injuries and the importance of the meniscotibial ligament, and how that may be related to extrusion of the meniscus. I think that's one of the unknowns. I do surgeries to try to recreate that belt system, to try to get that meniscus to not be as extruded as much after I do the repair. The reality of the situation is I don't know how good and how successful that surgery is. I think it's one of those things that we do it now because it's what's available to us now to maybe try to help with the problem. But I don't know if that's the definitive problem because we need a better solution to this. So that's one area. It's just understanding meniscus extrusion, how to prevent it, and then once it happens, is it even reversible? Because I feel like if it's not reversible, and even if you repair something, the meniscus may not be functional. So that's one area. The other one's in the area of meniscus transplants. I showed you that case. That's a fresh meniscus that we put into that patient, meaning it was harvested from a donor, put directly into the patient. Most of the meniscus transplant literature is based on meniscus that you actually harvest and then freeze in the freezer, and then you put back into the person. In those scenarios, like how durable that meniscus is probably not a surgery, at least that we typically tell patients is it's usually not a once in a lifetime type surgery. We still think of it as something that potentially can wear down over time, and then you have to do another one again. So it's kind of like a change the tire every once in a while type situation. Can we get the transplant, with fresh meniscus, can we get the transplant to function as a once in a lifetime surgery, like cartilage transplant surgery has data that says you can survive out to 20, 30 years. Meniscus transplant right now is not quite like that. But that's what we would like to get it to. So those are kind of two areas I think could still be areas that we need to understand better and come up with better solutions.
Thank you. And also thank you for the great presentation. I really enjoyed seeing the videos, giving those examples for us.
Yeah, absolutely.
Hey, Dr. Ma, my name's Sagar, and my question for you was over your this is a little bit unrelated, but like over your long career as a surgeon, what would you say is the surgical procedure that was that you would say is the most enjoyable or gratifying for you?
Oh man. To be quite honest with you, I would tell you, like, the reason I fell in love with arthroscopy is still the reason I love arthroscopy. I enjoy just doing a simple knee arthroscopy. Like, if I can have a meniscus debridement surgery, even though I just told you that you should try to save the meniscus as much as you can, I enjoy like those instances where there is a incarcerated meniscus, meaning the meniscus is torn, but like it's flipped underneath and it's stuck, and prying it out, relieving that pressure and cleaning up that flap tear. That's tremendously helpful for a patient. But that's what got me interested in sports medicine. Honestly, it wasn't to hang out with athletes. It was really the arthroscopic surgery. And so that's a very simple arthroscopic surgery, but I still love it today. Like, I do complex things, but I really enjoy the simple. And so that's still, when I can have that surgery, I can do a very elegant, minimally invasive surgery. Like, I love it. Like, and so it's still my favorite surgery to do. It's just a simple knee scope.
Thank you, Dr. Ma. Appreciate it.
Hi, Dr. Ma. My name's David, and I really enjoyed your presentation. I had another quick question that I wanted to ask. It was actually something that you mentioned in your presentation. I was wondering what you did in the case where the stitches wouldn't hold on the 60-year-old patient, and how you kind of like maneuvered that process.
Yeah, I think, so in that particular scenario, I tried multiple times, and it became really evident that the tissue was very poor. And so in that situation, all I did was just clean up the loose edges. So it ended up being a debridement. Because that's all I can do. I went from the sutures that we use come in different shapes. And some of the sutures, like for example, like if you have a flat suture, that's kind of like a tape, it has a little less, it's less abrasive and potentially less likely to cut out. We already use flat tapes to minimize cutout. So we already done a variety of things. I even went wider in terms of like from the margin of the tear to try to get to more healthy tissue. And it was just one of those situations where the guy is not healthy, and he was also a guy that has undergone chemotherapy for cancer before. So biology wise, I think there may be some things about him that made him a little more frail than most normal people. So in addition to his age, I think his health condition also kind of impacted it some. But in that situation, I tried everything and it just couldn't work out. And then you just kind of then try to do no harm. So you just kind of try to clean it and then just hopefully have that be enough. Unfortunately for him, it was enough. So it got him enough pain reduction that he was able to get back to where he can walk and do stuff without having severe pain in terms of his knee.
Hello, Dr. Ma. My name is Akansha Kanyal. I'm an incoming freshman at the University of Arizona. My question was based more off of your organ transplant. I was wondering if there's any new technology that's more prosthetic type that could possibly replace having an organ transplant that would be more stable.
Yeah, that's the holy grail for meniscus transplants. I think people have worked on this for a long time to try to come up with a suitable prosthetic implant so that you don't have to get organ donors anymore. And there is an approved implant that is used made by it's used to call CMI. I don't know exactly which company owns it now, but it is a prosthetic implant that you can potentially use to make up for some defects. And the outcome for it, I think, is kind of mixed. and that just kind of gets you to kind of really understand like how amazing the human body is, right? We have a lot of smart people that work on this and try to figure out how to like design a biomaterial that's like the meniscus. But like, that tissue is so intricate and it has some physical property that we still can't replicate today. But it is something that people are actively working on. And I just, I think it's one of those situations where it's just like cartilage. There's a lot of people spend a lot of money trying to engineer cartilage, but like end of the day here, you still can't create what you were born with. Like, and so the property of that is just remarkable, and that's why you're kind of humbled as a surgeon doing some of these things, because like even though you may think you're great, the reality of the situation here compared to like the normal, it's hard to recreate that with a human hand, at least in 2023.
Thank you.
Hey, Dr. Ma, my name is Samuel Halim. How are you doing?
Hey man, what's going on, dude?
Good, how are you?
It's going all right.
Nice. I have a question for you. So in terms of making the decision on how you're gonna be opening the knee, like what view you're gonna be going from based on the MRI, like what are the criteria you look for when you're looking at your MRI before you...
When you say open up the knee, do you mean like gapping the knee so I can see?
Yes.
Yeah, I think that's an in the surgery decision. If I can't see it, and then if I try to flip that probe, which is 5 millimeters, I didn't point that out, but that probe that I was using, that metal probe that I was trying to flip it end on end, that's only 5 millimeters. And so if I can't flip that, usually that's pretty tight, and that means I can't see the back of the knee at all. Then I'm gonna go ahead and loosen it so that I can at least flip it so it's end on end without scraping the cartilage, because that usually then for me is enough room to see and work without scuffing the cartilage. So that's not necessarily based on the MRI. It's really once you get the person to sleep and you try to stress the knee joint open, it's hard to explain. You basically have the person's knee on the side of your hips and you kind of leaning into the person and try to open up that joint. If it doesn't open up enough to let you do the work without scuffing the cartilage, which is an important tissue too, then I release it and get it open a little more. So.
Okay, thank you very much.
So thank you again, Dr. Ma. A question I have is, with these younger athletes that you attempted with the allograft, meniscal replacement, what degree of, I know this is a tricky question, but what is the degree you think of osteoarthritis before you abandon that and think about a total knee for a young athlete?
Yeah, I think so. I think, for me, they have to have reasonable cartilage left on the opposing surfaces for you to do a meniscus transplant. Yeah. And so what's reasonable, quotation mark, it's kind of surgeon decision-making, but I think most of us would think grade 2, meaning you can have some loss, but you can't have exposed bone, like on that knee. And so long as you don't see that, and it's mostly there, you don't have to be perfect. I mean, ideal is perfect. Ideal would be like it's perfect. But a lot of times in these individuals, because they've had multiple knee surgeries, they don't look perfect. But like you got to have at least some. And so I think grade 2 is the answer that I think most surgeons would accept. And like, joint replacements, obviously for a 19-year-old, no matter how bad it is, like, it's just not a conversation that it's going to make any orthopedic surgeon like super comfortable. I just think that's, and so like now what you're seeing even at our place at University of Missouri is that we're doing, pretty complicated, complex, like quote unquote joint reconstruction, or you could call them replacements, but with biologic parts, where you resurface both the top, bottom, and the meniscus, just to try to save that, just try to get something that's maybe more durable, because mechanical parts just like any mechanical part that you go out and buy, purchase, right? They have a finite shelf life, meaning lifespan once you put it in. The hope is obviously with a biologic tissue that's living, that has a chance to repair itself, is that that's more durable in the long run. But that's definitely a challenging situation. A young person that has a significantly damaged joint where you can't salvage it because the damage is too severe. And so, fortunately for us, that scenario doesn't come up very often.
I understand, and it's kind of unique. The reason I asked is due to the fact that I think when we were over there on the sports medicine service, we did see a 27-year-old with significant cartilage loss. And that was because she was a focused early on basketball player. So she had been playing basketball from age 6 or something, the father said. And she's living with the pain at the moment. Well,
Yeah.
the last I saw, she definitely needed a total knee.
Yeah.
I'm pretty sure she would probably need both
Yeah.
eventually.
I was going to
But,
say, even with some of the surgeries that I would do, like for example, that meniscus transplant, right? I don't know if that's a surgery that, at least for me, I think that's debatable, because I think there's data out there that suggests people who have athletic careers after surgeries like that. I think, for me, it's definitely surgeon experience, surgeon choice. But for me, I don't know if that surgery is a return to sport surgery. And so a lot of times when you're doing these complicated surgeries, you're not necessarily saying, I'm going to do this surgery so you can go back out and resume your collegiate career. I think you hope that it can be active, work out, but there has to be substantial lifestyle modifications, I think, to make that surgery last. And so those are the difficult conversations that you have to have with people to understand what the goals of the surgeries are and what do you think is really reasonable or achievable. And so, those situations are tough, for sure.
and not only that, she was very, the patient, I guess, was in shock that was proposed to her, and very reluctant to even accept the amount of damage she had done to her knees.
Yeah.
And it was just a very difficult I clearly remember it was a very difficult conversation overall.
Yeah.
And she was very upset that, they even brought up the idea. I'm sure that, even a 19-year-old is unfathomable to just even imagine that. But I'm just saying it's a very challenging conversation to try to present that idea to a patient, let alone for them to be receptive that, you're in so much pain, you have quite a bit of arthritis, and it's just going to get worse bone on bone.
Right.
The pain. On that note, let's save the meniscus.
That's right.
Save the meniscus, everyone.
Yeah, there's like
We're
hashtag
gonna
save
put
the meniscus.
We're gonna put the
That's right.
bumper sticker for you, Dr. Ma. We're gonna get a bumper sticker. Oh,
All right.
Sagar?
So it looks like a pretty strong group here. I like it. So
Sagar, you want to conclude, or then we can?
Yes. So before we have the rest of the interns also introduce themselves, we'll go ahead and get a little group picture for our marketing and social media and all that. So I'll
okay.
right. So if everyone could smile, 3, 2, 1. Got it. Thank you, sir. And that is it for our week 6 summer lecture series. We had Dr. Richard Ma. Again, a very good presentation on the meniscus. We hope to see everyone else tune into our next guest speaker for next week. Thank you all for listening